Hi, my name is Elisa Minkin. I'm a general pediatrician and I'm chair of the JOMA Preventative Health Committee. And I'm here today with Dr. Ellie Carmody. Dr. Carmody is an infectious disease physician. She received her medical degree from Mount Sinai School of Medicine and a master's of public health from Columbia University. She completed a residency in internal medicine at New York Presbyterian Hospital, Columbia University Medical Center, and her fellowship in infectious disease at NYU School of Medicine. She is currently an assistant professor in the Department of Medicine at NYU Grossman School of Medicine and is the director of infectious disease clinic at Bellevue Hospital Center. And so I thank you so much for joining me today, Dr. Carmody.
Well, thank you so much. It's always my pleasure to be here, and thank you so much for the welcome.
And you have joined us several times, so I really appreciate it. And I want to go back to the very first time, and this was in February when we were just starting to see COVID, and you did the first talk with Dr. Maureen Nemetsky on COVID-19. And the title was that, as I remember, it was, I'm not sure the order, don't panic, wash your hands, and be prepared. And
That's right.
yeah, I don't know if it was that exact order, but those three things are just as relevant now as we hopefully head back to school. And so that's what I want to talk about today, back to school. And hopefully this will help people be more prepared and hopefully be less anxious about this.
Wonderful.
Because I'm finding that is really what seems to be on so many people's minds now: parents, children, teens, college students, teachers and other school staff, and grandparents, how we can stay safe and healthy while the kids go back to school, or, potentially stay at home and learn in other ways. Each person will have their own unique risks and benefits to consider. We're also all in this together. I mean, I'm so tired of hearing that, but it's true. And what we do as individuals affects many others. And what we're really going to talk about is risk-benefit analysis with tremendous uncertainty, because that's what COVID-19 is best at: uncertainty. There is just an unbelievable amount of uncertainty. But one thing is for sure: as children go back to school, they're going to get sick more often than they did in quarantine, and this is going to bring up a lot of challenges. So I want to start with talking about testing for COVID-19. It's somewhat changed. And I think that if we go into great detail, we'll maybe understand the limits and what we can do with the testing.
Yeah. So, I think to sort of sort out the basics, there are diagnostic tests for COVID-19. Those are the tests that tell you, do you have the infection? Do you have the virus circulating? And then there are the tests that tell you whether or not you have antibody to COVID, as we've heard so much before. And that means, have you been exposed to COVID in the past, and you may have recovered from the infection, but it's really a test determining whether or not you've been exposed to it in the past and have had it in the past. With regards to that diagnostic testing, or do you have signs, or do you what's called the nasopharyngeal swab tests that are going to tell you if you have the viral products in your body? There are now several different types, and the testing environment is getting increasingly complex. So you have now the sort of more traditional laboratory-based tests, which are done and sent to a reference laboratory and run there. Those usually have like a slower turnaround time, 2 to 4 days in general, or even longer sometimes, depending on how much the backup is. Those are called PCR-based tests. That's, again, testing for the genetic material of the virus in the nasopharyngeal environment. You also now have what are called the rapid tests, and those are also tests that are, for the most part, most of those tests are also testing the genetic products, but they're rapid, meaning that you can get a result, let's say, within an hour safely. And then there's another test called an antigen-based test, which is another test for the viral proteins. All these tests have different, what are called sensitivities, specificities, and essentially they all have what's basically being said by that is they all have different levels of accuracy. And right now, because everything is so new, we often don't know exactly how accurate these things are. And so I just think it's important to say that will be tests that are inaccurate. That when you get a result for a test, it's difficult to say with 100% certainty that result was accurate. Did you want me to go into a little bit more about that?
Yes.
Because I'm
Yes.
happy to do
Give
that.
some examples so we can really understand. Because like my
Sure.
biggest concern is when people get a negative test and they really trust that result and then it ends up not being true.
Right. So I think that, so there's the concept of sensitivity, which means that let's give an example. So let's say that you have 100 persons getting a test for COVID-19, and you have a test. Let's say it's a PCR-based test that has a 90% sensitivity. That will mean that 90 of those 100 people who actually have COVID, let's say, 100 people who have COVID-19 get a test. 90 of those people who have COVID will have a positive result on that test. That test will show a positive. 10 of those people, of those 100 people, will actually have a negative test, even though they have COVID-19.
Right, we're talking about 100 people who have COVID.
Exactly. So that means that's what corresponds to the 90% sensitivity rate. So again, those 10 people, even though they actually have COVID, they had a negative test result, and that's called a false negative. So then on the flip side, you have what's called specificity. And basically the specificity reflects how can you trust what's called a true, you're trying to determine what the true positive rate is. So with specificity, you want to know, that will tell you, if you have a test that is 90% specific, you have 100 people who do not have COVID-19. They get the test. 90 of them will have a negative result. 10 of them will have a positive result, even though they do not have COVID-19. So those 10 people have what is called a false positive result. And that's problematic too. But I think, because they're going to end up having to isolate, and that's a pain in the neck.
Right.
But, I think in this setting, the more important test that we're trying to avoid is having a false negative test, meaning you want a very highly sensitive test, because a false negative test, you could run into trouble and you could be transmitting to other people based on the negative, thinking that you have a negative test, but you actually may have COVID-19.
Do you know what the false negative and false positive rates are on the rapid test versus the traditional swab?
Oh, I think it's so hard to say, and I think that I would say for the most part that they are going to be slightly less accurate than the traditional swab.
How accurate is the traditional swab?
Let's give it around probably 82% has been the highest figure that I've seen in terms of the sensitivity of the test.
Right. So that means that 1 out of 5 people who have COVID will falsely test negative.
Yeah, that's about right.
That's not amazing.
It's not amazing. No. And that's why you always have to have a very high, what's called index of suspicion. If you have symptoms like loss of taste and loss of smell, or, fevers, you really have to think about and treat this as COVID-19, even though you may have a negative test.
Right, and I think the other factors would be how prevalent, how common it is. I know that when it was peaking here, my son was a resident, and he didn't care. The test result showed it was COVID. And a lot of times they would repeat it several times before they would get the true positive. So if it's, I would think that the opposite would also be true. If it's really low, like thank God it's really low right now, that there's a much greater likelihood that a negative is a true negative.
Exactly, right. So for example, if we test in a setting where there's a lot of COVID-19 around, it's more likely that persons who test positive really do have the disease than if the test is performed in a population with not a lot of COVID-19. So again, we're less likely to believe those positive tests in a environment where there's very, very little COVID-19, I guess. But I think I guess perhaps the better thing would be to say that we're more likely to believe the negative tests in a population where there is very little COVID-19.
Right. I mean, I know with the flu, when I see a positive flu test before the season has really started, I'm deeply suspicious of it. I'm also deeply suspicious of a negative test when flu season is raging, because I know that
Absolutely.
it's not a very sensitive, the rapid flu test, the one that we've been using anyway, has not been that great. And there's about, I think, a 50% sensitivity, meaning it's 50% of the time it's a true negative and 50% of the time it's a false negative. But early in the season, I think it also has not such a great specificity, meaning that I think I'm saying this wrong. I know we talked before about positive predictive value and negative predictive value as opposed to sensitivity and specificity. So when we talk about trying to interpret the test, and we're getting very technical here, but when we're talking about trying to interpret the test, we have to take into account the prevalence, how common it is. That would be the bottom line for that, correct?
Yeah, yeah,
But
right.
we don't want to dismiss a positive as a false positive, because that could be
Right, no,
so much more
absolutely, we don't.
dangerous. And
Yeah.
also, unfortunately, and I think we should talk about whether it's over here. Some people are saying even some communities have herd immunity, because the truth is, I'll just summarize it. The truth is that even though there's low prevalence right now, say in the New York, New Jersey area, most areas, it is still ongoing at a low level, and it's surging in the rest of the country.
Right. And I think that we're at risk also, for, even though, in New York, for example, we have the 14-day quarantine
Hmm.
for people coming in from these high-risk states,
Hmm.
clearly we're at risk for sort of reseeding our population at
Right.
any point, and then things sort of, recrudescing or blossoming, unfortunately, from there. And so I think that it's something we really have to maintain vigilance about.
Right.
And I think this goes back to your point about, just being sensible and doing what we know works. And
Hmm.
those things are, hand hygiene,
Hmm.
social distancing,
Hmm.
masking.
Yes.
And I think if we do these simple measures, and again, I don't want to say that they are simple, because I recognize that they're complex and they're hard and masks are uncomfortable and these things. But
And it's summer.
yeah, I think that if we can do these things, we'll really get through this until there's a vaccine, and we can really try to avoid a surge again.
Right. And what do you think about this concept of some communities having herd immunity?
To be honest, I think that it's possible,
Hmm.
and it's possible that that the infection may not sort of uh, come to a point in which everybody in that community has infection again. But I think that nobody's existing in an island. And I
Right.
think that there are still going to be people within these communities who have not had exposure, have not had infection,
Hmm.
and they could potentially be exposed, to virus at any given point. And we don't want those vulnerable people getting infected again.
Exactly. And
Uh,
those might be the
or
people who are the ones who are the most careful, precisely because they were vulnerable and they were
right,
careful
right.
early.
Exactly. And so we do have a lot of people who have been quite careful. And so
Right.
are, we certainly have not, as a, I'm talking about for example, the New York City area, we haven't achieved as a city herd immunity
Right.
by any stretch of the imagination.
Right.
So I think that there are still so many vulnerable people. And as these, we're talking about schools here, as these children come back to school, um, they've never been exposed. Their parents have never been exposed. Their grandparents have never been exposed. So we really have to think about what we're doing as a community overall to protect the members within each community who are naive, who
Right.
are
And I want to get back to masking. It's such an important topic, even though it's also hard to do and everybody's heard enough of it, but you haven't heard enough of it, because it's so important that when
mhm,
you're wearing a mask, right, you are to some degree protecting yourself. It's not that you're not protecting yourself, but the greater use for it is to protect others.
right. Exactly. So what we're thinking about with masking is this idea of source control.
Hmm.
And source control is not only important, as we've learned,
Hmm.
unfortunately, as a country, we've learned this late. Like, we used to think that source control was only important for people who actually had symptoms
Hmm.
from COVID-19. And then we learned that a lot, 40, almost 50% of transmission can be occurring in people who are what are called pre-symptomatic or asymptomatic, meaning they don't have symptoms for COVID-19, or they have, or they're about to have symptoms for COVID-19, but they don't quite have those symptoms yet. So there is a lot of asymptomatic transmission that occurs, and it's because at any given point we may not realize that we have COVID-19. We may be transmitting to somebody else, that we want to basically mask and block all of our respiratory droplets that are called, these are the mechanisms, the primary mechanisms of transmission, that we want to block those droplets and prevent them from getting onto other people, into their eyes, into their onto their mouths or noses, and to prevent them from getting COVID-19.
Absolutely. And again, we mentioned before that there are hotspots in many, many states that require a quarantine upon coming to our area. I don't think it's actually being enforced.
Yeah.
So that's why you should really be assuming that anybody you are in contact with could be positive.
Right, right. And, you know, the enforcement, I know it is difficult. And I think, you know, as Americans, we always think about, you know, oh, this doesn't really apply to me, and it'll be fine, and nobody's going to track me, and I'll be careful. But, you know, in reality, you know, the idea that people are asymptomatic and can be transmitting is really concerning. And I think we really do have to be careful. And we really do need to hold ourselves to that standard of, you know, maintaining distancing and quarantining before we interact with, you know, people in our social environment.
Right. And it also is the law in New York, right?
It is the law.
So if
Yes. And
you're
I
in
think
your
there's a
own,
$10,000 fine for people
really,
who
really?
find out are violating that quarantine.
Wow. I mean, it's also important just because Dina de Machuca, Dina, the law of the land is the law,
Right.
and also
Right.
protecting our most vulnerable. I mean, these are all very good reasons for doing this when you are in public where you can't social distance. Many other situations where you don't need to, like in your own home, or if you are in a community setting where everybody agrees that they're all part of the same bubble, so to speak. And
if I could just address one more thing about masks. I think there's been a lot of confusion about how a mask should be properly worn. And there have been people who have said, oh, it's not important to cover the nose. But again, the nose is producing droplets.
Right.
And we produce droplets by breathing, by talking, by coughing, and by sneezing. So the mask should cover the nose and the mouth. And it's really hard, I know, to find a comfortable mask. And you may just end up having to try a couple of different types in order to find something that's comfortable for you and comfortable for your child. But I think that it's really important that the masks cover the nose and the mouth. I mean, it's been very clearly demonstrated.
Right. And while we're actually on the topic of masks, exhalation valves. Can you comment on exhalation valves? Explain what they are and why it's a problem.
Right. So the exhalation valves allow basically unfiltered or very poorly filtered air to escape when you're breathing, right? So the exhalation valves are created for the wearer of the mask to have a more comfortable mask, basically because it won't prohibit exhalation. You'll be able to exhale your air easily. But what does that mean in terms of COVID-19? The whole reason that we're wearing the mask, not the entire reason, but the majority of the reason we're wearing the mask is because we're trying to prevent our own secretions or our own droplets from getting on other people, our own aerosols from getting on others. So basically, that's allowing all of those droplets to escape. And therefore, the whole reason for collective protection by masking is lost with these exhalation valves. So don't get that one.
Right. Those are the ones that you can see the kind of little openings on the outside, the little circular openings. And
yeah, the little black device or the opening.
Right.
Yeah.
One person told me, but it has a filter, and I believe it's a one-way filter. And I think that these masks were originally created for people who are working in dusty environments or other toxins in the environment to protect them from the environment, not for medical use.
Exactly. You'll never see a surgeon wearing that type of a mask, right?
Right. Or you shouldn't, right.
Yeah, you know, just think about a surgeon. Like the idea of a surgical mask is to protect a sterile field. We've known about this since 1914, you know, earlier than that. So you want a mask to basically prevent any droplets and respiratory droplets from entering a sterile field, because they contaminate that field. And so you want that covering the nose, covering the mouth, no exhalation valve. And that's the sort of, that's what we're thinking about in terms of the COVID-19 and masking.
I want to come back a little bit to masks just when it comes to going back to school for the staff and for the children. But speaking of children, I do want to talk about, there's been a lot in the news about how much children spread and get COVID-19. I know there was a tremendous amount in the news about the inflammatory syndrome. It terrified people. It's also very rare. But could you comment on children as spreaders of COVID-19 and how severe they get it?
So in terms of spreading COVID-19, I think young children are, they're much less likely, I would say, to spread COVID-19 than adults or adolescents.
Why? It's so surprising. We're not used to this. We're not used to this.
I know.
We're used to children being like petri dishes.
No, that's true. And it really is very different than the flu, for example. With the flu, we're really thought, we know that children are actually, a lot of the primary drivers of flu and community levels of flu. But in COVID-19, they really do not seem to be. They often are, infected, but they get the infection from an adult rather than passing it to each other or passing it to adults. And again, this is referring to young children.
I know there's a lot of hypotheses.
It's not possible. I think it clearly does.
Right, less likely doesn't mean that it doesn't happen. It just means it's less likely. But to me, it's somewhat reassuring about going back to school. And I think the age limit in terms of the likelihood, and of course it's not a set number and it's all a matter of percentages, would be 10 and under.
Yeah, no, that's correct. So there's a large South Korean study that looked at, these different age groups and, essentially really it was a very carefully done study that looked at, kids and then how many people were infected based on the index, the kid who was perceived as the initial person infected from somebody from outside, and then how many family members and how many other people got infected from that child. And so, so I think that the rates that they came up with were for young children under 10, it was 5 out of 100 people were infected from a child under 10. And then for older children, so 10 and over, it was basically 19 out of 100 people got infected.
I think it was 10 to 20, right?
10 to 20, sorry, 10 to 20. So, we know, and it makes sense. I mean, a 16-year-old is physiologically much more similar to an adult than they are a 5-year-old. So it's not something that we wouldn't expect.
Right, but it was a little surprising to me that they were actually the highest spreaders. I think the other numbers were lower than 19%. And that was something that I think was new to us, that kids, because they're still kids, right? Middle school kids, 12, 13, they're still children. It sounds like they are very effective.
Oh, I see what you're saying. Yes, yeah. So I think that what we perceived as being a kid really has shifted, with this study. And, now we know, and I'm thinking about my own son and, the fact that, he's 11. So I have,
it's not black and white.
Children.
I'm sure that there's, a gradation. As you get closer to 10 and above 10, but it's good to know that those littlest tiny, preschool age children don't seem to be, little walking petri dishes for COVID, little, super spreaders of COVID, which doesn't mean you're safe and you don't have to wear a mask around them. But these kids are not going to be able to wear masks, particularly reliably. So that, that is to some degree reassuring. It doesn't mean that the adult taking care of them shouldn't wear masks. Oh, they should.
Exactly.
Oh, they should.
And a face shield.
And a face shield, please. So it's just important for keeping in mind as teachers and staff goes back to school.
Right.
And I think there's also a tremendous fear. I'm sorry, but there's also tremendous fear, because I'm talking as a pediatrician here, there's tremendous fear from the stories of the inflammatory syndrome that children are going to be so sick from this disease. And they do get it, but for the most part, they do very well, especially the younger ones.
I mean, it does seem quite rare. And I think perhaps you probably know even more than me about this as a pediatrician. But but yeah, it does seem rare, and I think most kids do just fine. And I think the thing to think about is like a lot of these kids may have such minimal symptoms, but it's again what we're going to have to be thinking about as we move into the school year, that even a runny nose could be COVID-19.
That's the problem. That's what I understand, is that children typically have just a runny nose, very young children.
Right.
I don't know what we're going to do in terms of distinguishing that from the common cold or other
Yeah,
mild viral illnesses.
I know. It's going to be very challenging. And then once we get into flu season, we're going to have to think about that. So I think the more we can vaccinate children for
Yes, quick,
flu
yes,
this year, I think that that's an important priority. So get your
quick.
flu shot early.
Right. Quick plug for the
Um,
flu shot and the very first podcast we did, which was How to Fool Yourself Less, with Dr. Jonathan Howard, talks about myths about the flu vaccine. So people can go listen to that one if they have concerns about the flu shot, please. Yes, get that early. Can we talk about what would be a reason to get testing, and what would be the isolation / quarantine in these
okay.
cases?
So I think as we move into the school year, we really have to think about this because
Mm-hmm.
the schools are going to want any kid who has symptoms to get tested, really.
Mm-hmm. Mm-hmm.
And these symptoms can be mild. And I mean, I think most of our schools are going to be conducting daily screenings, whether those are symptom screenings and they're having the parents kind of like sign off that the kids don't have symptoms. They're going to be asking things like sore throat, runny nose, of course, fever, nausea, vomiting, anything, right? And runny nose. So they're going to be asking about these symptoms, and the kid is really not supposed to go to school with any of these symptoms. I think that this year is really the one year that you really can't send your child to school with any symptoms of unwellness. It's
Right, and
very
I just want to take
important.
a minute and quote Dr. Maureen Nemetsky, who was my former co-chair and my colleague and friend, who said, "This year, school is a privilege, not a right, and please don't
Mm-hmm.
give your child Tylenol or Motrin." I mean, everybody knows that happens all the time. People have to go to work, the child has a little fever, and they just give them Tylenol or Motrin and send them to school. That should not ever happen, but this year, it's so important not to do that.
Right. Because what happens if you do send your child and they have a little fever and then their fever recurs during the day? That's going to send out an incredible chain of events that's going to end up shutting the school down, or
Right.
at least shutting that classroom down, making the teacher go into quarantine until you have a test result, making all other children in that classroom go into quarantine until there's a test result. So I think, it's very complicated.
And that
Um,
also speaks to the limits of temperature checks, because I've heard of schools who are saying, well, we're just going to run temperature checks. I know that Gourmet
mhm.
Glatt used to have, temperature checks. Some stores would have them. Um, and especially for children, that's so limited, putting aside that they may have had Tylenol or Motrin that morning. Don't do that. Um, but even without that, children, as we said before, may not have fever. Adults may not have fever, but children certainly may not have
Right.
fever and still have COVID.
Absolutely.
Yeah.
Absolutely.
So what would be the different scenarios? Let's start with a child that tests COVID positive
Uh-huh.
and has symptoms. When can they go back to school?
They can go back to school 10 days after isolation begins from their
Mm-hmm.
first date of symptoms.
Mm-hmm.
And, that 10 days has to include that their symptoms are improving
Mm-hmm.
and that they've been without fever,
Mm-hmm.
off of fever
Medication.
reducing medications for
Mm-hmm.
now 24 hours. It used to be
Mm-hmm.
72, and they've actually
Mm-hmm.
shortened that window to 24.
Mm-hmm. Mm-hmm. Good. Okay. What about their family members?
So that's actually complicated because um, with family members, you're presuming that those people cannot maintain any social distancing from the child. So if they cannot maintain any social distancing from the child and they're continue to care for the child where they're ill, that duration of quarantine would have to extend for 14 days from the end of the isolation period of the child. So that means you're getting into 24 days of quarantine total for those family members.
For those who can't separate from the
Exactly.
child.
And then let's say we're talking about a child who's in the class of that child. And then, we're obviously separated on the day in which that child was symptomatic and went and got tested and then was removed from the school. Those children are going to have to quarantine for 14 days. So
Can you test out of quarantine?
No,
Can you test out?
You cannot test out of quarantine. And that goes back to the whole sensitivity and specificity of the test. So, we can't believe that the results of these tests and let these kids back into school. And that's really, New York State policy, that's CDC policy, and the schools are never going to change that policy.
Right. I mean, I think part of it is you're saying it might be a false negative, but I think the larger part could be there's a whole 14-day period where symptoms can occur. And a lot of people who've been exposed say, well, when can I get tested? I want to get tested right away. You get tested on day 2, you can get tested on day 4, you can get tested on day 6. It doesn't really matter if you're negative.
Right.
It only matters if you're positive.
Right, exactly.
If you're positive, you can shorten that 24-day period. So
right.
That's when it's useful. Say you're the mother of a child and you want to go back to work.
Mm-hmm.
And what would be a good day to get tested then? I mean, this is really not a question with a right and wrong answer. I think it's just a practical point.
Yeah. Oh, I mean, I think that you would probably, I would say, let's say your child has symptoms, maybe you would get tested, I would say 48 to 72 hours after that. But I mean, you could even be tested the same day. It's just, I think it doesn't really matter, but I think that you do want to be tested to know, obviously, and then it can shorten the duration of your isolation your quarantine if you end up being positive. And if you're positive again, then you start from the 10 days. You start counting from that first day in which you had your positive test. Even if you may be asymptomatic, it's the day of your positive test. You do 10 days.
Right. I mean, it makes the most sense to me to be tested at around day 4, just because the greatest likelihood upon exposure, right, would be by 4 days, even though it can extend to 14. I mean, if you test too soon and you're negative, it doesn't help you at all.
No, that's true. That's true. But I'm just thinking that if you're the mother of the child, you're constantly exposed to the child. So it doesn't exactly, I don't know.
Right. I mean, it would depend on how many days it was from exposure, more so than a positive test.
Right.
You want it to be, I would think, at least 4 days from your exposure to maximize the chance that you have it.
Yeah, I would say 72. Yeah, 72 to 96 hours.
So 3 to 4 days. That makes sense.
Yeah.
And that again only helps you if you're positive, because then you only have to wait 10 days with 24-hour fevers free and no symptoms, as opposed to potentially 24, which is insane. That's a very long period of time. And the alternative would be for somebody to, once they know their child is positive, right, to stop being exposed to them. Now, you could, even if you have to care for the child, right, mask, wash your hands, distance, right, if the child is old enough.
Yes, absolutely. I think that, if they're not a young child, you can separate within the household, and therefore you can shorten the duration of your own quarantine.
And separate everybody else.
Yeah.
Right, so they don't have that huge ongoing quarantine period.
Yeah. And I just remember from the beginning of this outbreak and how hard it was for families in situations where you have one child who was officially kind of, that they were under quarantine or they were isolated because they had COVID, and what do you do with the other family? I mean, it's just a mess.
Right. And if you live in an apartment building, I mean, you're not even allowed to go into the common hallways.
Right.
It's super, super hard. Okay, what about someone who tests positive but has no symptoms?
That would be
talked about that.
Yeah, so 10 days from the date of the first positive test.
I think that's actually a new thing, so it's shorter.
And then I would just want to say that, I think we all know this now, but, there's the whole thing about the positive PCR tests are still having the viral RNA for weeks, if not months, after one tests positive. So once you're positive, I think there's very little utility in doing any repeat
Right.
PCR testing after that.
Right. I think there was a way to get out of isolation with 2 negative tests in a row. I just don't think it's practical to be able to get that and get it back so quickly.
Exactly. Yeah. I think it's just not, yeah. I mean, you just end up, with another positive test and you're kind of like, well, what do I do? Why did I put myself through that?
Right, right. It can remain positive and it doesn't mean anything. And that actually is a great segue into the concept of reinfection. Does this happen? And what would
Mm-hmm.
be the scenario where someone would be, because the classic story is the person was positive and then they were negative. They had antibodies and then the antibodies were gone and then they tested positive again. Is that reinfection?
I think that reinfection is probably going to be the exception rather than the rule.
Rare.
I think it's going to happen, but I think it's going to be rare.
Hmm.
I'm hoping, at least for the short term, and I don't know how long I can be able to say that. Am I going
I
to be able to
know,
say
I
that six
know,
months from
I
now?
know,
Maybe not.
because right, because when we say a community may appear to have herd immunity, and we don't want to say they do, it's possible that they as a community have very low ongoing transmission that could change as immunity wanes, and that's a separate concept of what does it mean when the antibodies go away? Does it mean immunity is lost or not?
Right. So I don't think we know. So I'm going to say that first.
Hmm.
I think it's very expected that the antibodies wane. I think this happens with most viral infections, that you
Hmm.
have a period, let's say 14 days after the initial infection
Hmm.
begins. That's kind of the maximum point of antibody production, 14 to
Hmm.
21 days. And then those antibodies will rapidly wane.
Hmm.
There's no reason for your body to keep them around, I mean,
Right.
and they will wane, and they may even go down to a threshold where they're considered to be undetectable.
Hmm.
There's a whole other branch of the immune system, which are called the T cells, or
Hmm.
cellular immunity.
Hmm.
Those cells um, also are responsible for preserving what's called immunologic memory, and they can, we believe that the T cell response is of a longer duration than what we are seeing with the antibody response. So the T cells, we know, I mean, I'm just considering from SARS, the
Hmm.
initial SARS
Hmm.
one. Uh,
Right, so you're extrapolating. I mean, we have
I'm
to remember that we
extrapolating.
don't know.
We
We
don't know.
don't know.
We don't.
Right.
But the T cell responses for SARS lasted 10 years.
Hmm.
So, we don't know what's going to happen with SARS CoV-2, but we believe that the T cell responses are probably more durable than the antibody responses in terms of what we're going to be able to measure. And will those T cells help preserve immunity over time? We're certainly hoping that they do. But
Right.
again, we can't say.
Right.
But I would just emphasize that it's expected that the antibodies go down, and it
Right. So,
may,
mhm.
I mean, hoping that it doesn't necessarily mean that you completely lost all immunity.
Right, right. So it's just so many things we don't know, and that might be the explanation for these supposed reinfections, that the antibodies waned, but the
Hmm.
PCR is on and off positive because there could be a false negative rate, and that may be what's going on. And when there's reported symptoms, there is talk of COVID with symptoms that can be ongoing for a very long
Oh
time, and
yeah,
that can wax and wane. So it's more likely that these
right.
stories are an ongoing initial infection.
Hmm.
But we don't know how long this immunity lasts. And we also, now that these antibodies that we're measuring are waning, we can't even say that a person is immune based on them. I mean, first of all, we don't know that. But second of all, they're waning anyway. So people have asked me, should I get an antibody test? And they remember an illness back 4 months ago. The likelihood is that their antibodies will be negative even if they had it.
Yeah, that's a really interesting point. And I think that, yeah, I mean, getting an antibody test now really may not tell you anything. It may not even tell you if you've been exposed or not. You may not be able to rely on it.
Right, which is the one thing it was supposed to do. Was I exposed to COVID? And even that,
Hmm.
it doesn't do it. We were never able to say that because you have antibodies, you are immune. Right. And
Right.
correct me if I'm wrong, but that type of antibodies that it's measuring is not the kind of antibodies that is used to fight, right? There's a different kind called
Yeah,
neutralizing antibodies, which it's not measuring.
exactly. Yeah. I think only the specialized sort of research laboratories are really measuring the neutralizing antibodies. Those are the actual virus killing antibodies. That is, these antibodies are, for the most part of these assays, are not even measuring the antibody to the spike protein. So, um, some of them are, but others aren't. So I think that we don't know yet if the antibodies that are being measured in commercial tests are those antibodies that are protective at
Hmm.
particular thresholds or levels.
Hmm.
We don't know what those levels are. We don't know if those antibodies are the ones that are protective. So again, those tests were developed more to establish whether or not somebody's been exposed or not, or had it or not. And now that everybody has waning antibodies from our surge in March
Hmm.
and April, we don't even know if that's a valid use anymore.
Right. It's a
So
separate topic when people say, well, I have antibodies, so I can do what I want. Again, we don't know. Not only do we not know whether those antibodies mean you're immune, but we also don't know how long that immunity, if you have it, lasts.
right, absolutely.
So it boils down to being careful. Another topic I just want to bring up is what if someone in the family, not the child himself, but a parent, for example, has been exposed to COVID? Now, if they're symptomatic and they have it, right, then those children are contacts and they have to quarantine
Uh-huh.
for 14 days, which you talked about before.
Right.
Um, what if the parent has some symptoms? Maybe they don't know they were exposed, but they have some symptoms and they're waiting for a test. Right?
Okay. So if they are waiting for a test, the parent really should, as much as possible, try to self-isolate,
Mm-hmm.
and should definitely mask in the household. And maybe have the other parent or someone else provide the meals for the children, bathe the children, have that close contact with the children while while the parent is waiting for the test.
I think also, though, it matters how common COVID is. If COVID is surging in your area, then I think you'd have to presume it's COVID. And then the children who are already exposed would have to quarantine waiting on the parent's test, right?
Yeah,
As
that's definitely
opposed
true
to
too.
it can take a while to get that test back. Or if the parent has very typical symptoms of COVID, like that loss of sense of taste and smell is so unique to
Hmm.
COVID in its more, obvious form.
Yeah.
So it may be something you may want to think about, that even if your test isn't back yet, if you got COVID tested and you're suspecting COVID, then you may need to keep your child home if your child's been
Yeah,
exposed to you.
exactly.
That was,
Exactly. I think, that's why I think a lot of the schools are screening not just does the child have symptoms, but does anybody in the household have symptoms of COVID? Because you have to kind of presume that the child could be infected if the parent has symptoms.
right, right,
So you really have to be careful about your entire household. That's why not just the children need to mask, not just the children need to socially distance, but everybody in the family needs to continue to do these things that we've been doing since March and April, which is, to socially distance, mask in public, and wash our hands.
right, right, right. Now, what if an adult in the family is exposed to COVID and has no symptoms? Now that person's exposed, so they have to quarantine for
Quarantine.
those 14 days. Does everybody in their entire family have to quarantine for 14 days?
No, they
Right.
don't. So
Mm-hmm.
those are contacts of contacts,
Mm-hmm.
and they
Second
do not
degree.
have to
Mm-hmm.
quarantine.
Right.
Um, Again, it's important that the adult who is quarantining, because they don't know if they have COVID, or they don't know if they're going to develop COVID during that 14 days, that they try to maintain as much distance as they can from the other members of their household.
Right. Quarantine from the family members. Otherwise, if they end up having it, then you have to deal with that
Right,
exposure to everybody else.
exactly. Then everybody's got to be tested if they end up having it. Right.
Right. So going back to school, I actually have a lot of parents ask me, what's my take, they say, on going back to school? Maybe they should just stay home. So
Mhm.
This is actually a very personal decision. I'm not going to ask you that as a question for you. It's really very personal. I find that people have different situations. They may have somebody living with them who is immunocompromised. That's high risk. That child's going to go to school and is going to get sick with something,
Mm-hmm.
right? And so you're going to have to think about that. Um, these we're not here to give medical advice. Please speak to your healthcare provider about this. But it's just really important to bring up that different people are going to have different situations, and there's a whole separate concept of risk tolerance. I find that some of my families are more on the anxious side and more on the cautious side. You cannot have school start without taking more risk. It's just built into it. You cannot say that you are going to 100% prevent COVID and have the kids go back
Exactly.
to school. So
Yes.
that has to be factored in. There are people who've, unfortunately lost a relative, a close relative to COVID. They may have lost, say, a parent, and the other parent is not maybe living with them, but wants to stay close with the family, and that's important for everybody's mental health, but that person's high risk. So every situation is different. The child themselves may have a medical condition, and again, speak
Mm-hmm.
to your healthcare provider. But these things, it's so important to think about them now.
Yeah.
Um, I also want to say that I do think we can have school and we can make it safer. It's going to depend on everybody working together. We talked about that before, about what people need to do about being, open and honest and monitoring everybody for symptoms and exposure, and being careful about doing that social distancing as much as possible, the mask wearing as much as possible, being careful about anybody coming in from areas where it's more prevalent, where they really do have to maintain that 14-day quarantine.
Yes, and I think with these measures, as you said, I mean, we can make it safer,
Hmm.
and we can get through this, and we can
Hmm.
have our schools be the source of, you know, much of this interaction that our children need. The interaction they need, the emotional support they need, the academic learning. I mean, these are,
Hmm.
these are incredible sacrifices that our kids have made over the last several months, and when our kids were not in school during the spring. So I know that we're all eager for our children to go back, and I really think that we can do this safely, or as safely as possible,
Right.
recognizing that we cannot, as you mentioned, eliminate the risk of
Hmm.
COVID-19. We're going to mitigate that risk. We're going to make it as small as possible, but we're not going to eliminate it.
Right. And
Um,
for some people, though, that even that smaller risk, first of all, may be bigger for them, for their
it
particular
might.
situation, or it just
Hmm.
emotionally, it may be too big for them. And there are other things that people can do. They can make their own homeschool, they can make their own smaller school, they can do some form of remote learning. So there are other options. I do think, though, that most of my patients have not really benefited tremendously from remote learning. And
Right.
as many of these kids that can go back to school, I think it is best for them.
Hmm.
So there are things that we can do. Class size, right? There's the concept of the pods where we have smaller subclasses and they're separated from the others, and they can be separated with plexiglass or classrooms. It's really going to depend on what the school can do, financially and with their, physical resources. Um,
Right.
Busing, bus
And I
sizes,
mean, and, I think that, I don't want to provide medical advice or advice for
Hmm.
anybody, but I can say that the, American Academy of Pediatrics is recommending that children, that
Hmm.
these are individual family decisions, but
Right.
that they hope that schools can open and provide these, that kids can go back to school.
Right. Now, masks for kids.
Right.
Again, it would depend on the age. The youngest children, under 2, AAP says no mask. It's not safe. Um,
Right.
Over 2, the younger children are not going to be able to be so consistent with this. And I think that the standard is that the teacher will wear both a mask and a face shield.
Mm-hmm. I would advocate for that.
Yeah.
I mean, I think that, once you get into kindergarten, once you get first grade,
Hmm.
I think those kids can wear masks. I do. I mean, my child is in first grade and she's wearing a mask. I mean, every child is different, but, um, I definitely think that the teacher should wear a mask and wear a face shield, particularly when they are close to children. So, if the teacher is at the blackboard or the whiteboard at the front of the class, maybe they don't need to be wearing a face shield at that time. But when they're next to children, what's useful about the face shield is that it really prevents these large sort of droplets. Like, let's say a child is not properly wearing a mask, and that's going to happen, a lot. And the child is not wearing a mask, and the child coughs. You have the face shield there, which is providing the eye protection, which is, again, we know that eye inoculation is one of the mechanisms of COVID transmission. They have a nice shield that's protecting them from those high speed, high large volume droplets.
Right, and glasses are not enough.
Glasses are not enough at all.
Right.
And that's going to protect them, and then the mask is going to give them an added layer of protection. And again, that's going to be source control for them, to make sure that they're not spreading to anyone of their
Right. I want to say a couple things about this. First of all, as a pediatrician, I wear this. I wear a mask. I wear a face shield. And we used to be afraid to wear the white coats. We were one of these practices that we didn't wear a white coat because, the children might see the white coat and they'll say there's a doctor and they'll be scared. And I come in with my white coat and my hat on my head and my face shield and my mask. And for the most part, they're fine.
Yeah, I agree.
They really do
I
well.
don't find them uncomfortable. That's the same thing with our clinic. We use a face mask. We use the face shield with every interaction. And even the supportive staff are using it. So the social workers, the caseworkers, all these people are wearing face shields and face masks. And we do it all day and we're fine.
Right, from our perspective. But I'm talking about from the children's perspective. You might think, oh, these poor children, they are seeing these scary looking grown-ups. Children are naturally resilient. And it's our modeling to them that's going to continue to reassure them, not what we wear or don't wear. Because I know some parents are very concerned. These children aren't seeing faces. They're seeing these people in get-ups. It's all how we sell it to them. It's all how we present it. And so it's really important for us, and this is in general with back to school, not to convey anxiety, but to convey optimism and reassurance. And I think, by the way, it's important to talk about this even to young children. They are aware of what's going on. I had a family who told their children, oh, it's just the flu. The flu season's going on for a long time this year. They were afraid to talk about COVID.
I don't know. I think it's important to be transparent with kids. I really do.
Very important. It makes them terrified that you're not putting a word, a name to something that they are aware of from very young ages.
Right. And I think, if I could just extrapolate a little bit about the face shields and the masks, I feel like by giving myself that layer of protection when I'm around patients, again, a lot of my patients aren't properly masking. They are uncovering their nose. This is happening all the time. By giving me that protection, that maintains my rapport and my relationship with the patients, as opposed to detracting from it.
Right. And I find that most of the parents are reassured. And I'll laugh about it. I'll come in and I'll say, I'm an astronaut. Actually, a 4-year-old pointed to me and said, are you an astronaut? But again, it's how we present it. But back to the teachers and staff, because that's also a concern that I have, that they be protected as much as possible.
I agree.
And I think that, there's a lot of talk right now. There's a lot of turbulence as the schools try hard to figure out how to make it as safe as possible for everybody, and hoping that, the prevalence continues to drop. But because you don't know about that asymptomatic, pre-symptomatic spread, it's so much better to be proactive and not say, well, I'll just wait to see if it comes back, whether or not it's circulating at high levels, and it continues to be there at low levels.
Right.
Right?
Exactly.
It's not that it's gone. And it's certainly, like I said, not gone on the rest of the country, and we don't have closed borders around New York, New Jersey. I think it's so important for people who work in the schools, who are by definition adults. They're at higher risk, and some are at even higher risk. And that's a separate issue, whether you should speak to your healthcare provider. If you're over the age of 60, you have an underlying condition, you really need to talk to your healthcare provider about whether it's safe for you to work, but in a school setting. But that's separate from this. For people who are going to work, they really should protect themselves. And I think it's important to say, get your own supplies. This is where preparing comes in. Get them now, because you may find one is more comfortable for you and another is not, and your school may end up providing you with something that doesn't work for you.
Exactly.
So preparing by buying it, stocking up on it, practicing. And the other issue that I will say as a physician, and I heard someone say, think about yourself as a nurse or a doctor. You a teacher, pretend that you're a nurse or a doctor and think the same way we do, which is that we are prepared regardless of our patient's symptoms. We walk in the room with that equipment.
Mm-hmm.
You do the same thing, be prepared. I will say that it's important to have breaks. I
Mm-hmm.
cannot wear this stuff all day.
Mm-hmm.
It's hot, it's uncomfortable. So I think it's important to be able to say, I need to be able to go to the break room. I have a room where I can go where it's safe to take this equipment off.
Right.
I think that's
And
important.
that hopefully that room is somewhere where nobody else is present, or at least they're present, at a significant distance away from you. Because again,
Right,
all of these teachers'
right,
lounges.
right. Maybe they need like plexiglass little booths or something. I don't know, but there has to be a way. Even if you go to the bathroom and you're in the bathroom stall and
Yeah.
it's important to get that little break. I mean, I have that issue too because I have a room where other people come in and out, and I have to be ready to put a mask on, when
Right.
someone comes in the room because we are careful about that. So, I mean, we have so much to talk about. I think we're going to stop at this point, and hopefully get together again, and talk more about this. Um, but I just want to say, keep in mind your entire family, including high-risk relatives. You may have to decide whether you're going to send your kids to school and start distancing from these high-risk relatives, or choose to keep them home. Um, and limit your circle to protect those more vulnerable relatives. Each family has to weigh their unique risks and benefits, and you should discuss that with your healthcare provider. And I have to thank you so much for doing this with me again.
Of course. Always my pleasure.
Thank you. Be well.
All right. Be well.